Everyone, good morning. Let me know if you can hear me. Hey, good morning, everyone. Let me know if you can hear me or not. Be able to. Perfect. Thank you, Alyssa. Morning. A lot of questions on the board, so thank you for putting those up there. I appreciate that. You guys are getting your questions. We'll start here in about a minute, and also I was going to cover the prescription assignment real quick, just to give you guys some heads up on that, since this one will be a little different than the previous one. Good morning. Of course, you guys are always able to put up questions in the chat here or on the sticky board. Either way is. All right, it's 8 o'clock. Let's get started. Second here. Sorry, I had some computer issues, so I'm trying to format a hard drive. So that's what I'm trying to make sure that I can save this stuff in case the thing went down. Oh, set this up. That's unfortunate, but almost go on. Anyway, all right. So we're gonna just do this. So let me cover a couple of questions that came up in the sticky board here. So just starting off. Someone said, what would be an indication for someone needing a spacer? How do you know when to prescribe a spacer? Spacers are good for people who have challenge coordinating when using a meter dose inhaler between pressing the canister and inhaling the drug. So you can see that sometimes with children. You can see that with elderly patients. And basically, the spacer serves as a spot to hold the medication sort of suspended in air until the patient can breathe it in. So if you have someone who's like that, that would be a good case to do it. If they have good coordination and you can educate them on the proper ways to use it, they don't necessarily need one. But it may be efficacious for those that have some challenges there. So that's what I would say about that. Someone said regarding anticholinergics, would the long-acting metiotropium be a long-term controller med, or would it be considered quick relief meds that last a long time? Just making sure I understand which box to put this into: quick relief versus long-term. So ipratropium, short-acting anticholinergic, is good for quick-acting relief. Tiotropium is for long-acting control. There's no real long-acting medications that are used for sort of quick relief of asthma symptoms. And on top of that, tiotropium would not be used for asthma anyway. That's just for indicated for COPD. So definitely for long-term control, I would say. Some said morning. Good morning to you as well. Slide 15, talking about CAP, text for inpatient. You mentioned 3 options: third-gen cephalosporin, ampicillin, and then a macrolide or a tetracycline. But your examples will include just the cephalosporin and the macrolide or tetracycline. Then the respiratory fluoroquinolone alone if beta-lactam allergy, preventing use of cephalosporin. But I assume the high-dose ampicillin is being used as well when it is used. Yeah, that's reasonable as just an alternative. So I just gave you some options there, but certainly the ampicillin could be used in place of a cephalosporin there. The ampicillin could be used, so that's perfectly reasonable. The thing is, and I think someone else had a similar question, is that the fluoroquinolone being used by itself is possible because it does have good coverage against the typical respiratory bugs we're talking about, but it also covers the atypicals, right? Ampicillin and the cephalosporins are able to cover all those respiratory bugs, but they don't get the atypicals. That's why you have to add on the macrolide to that. So, but because we do see a decent amount of resistance to the fluoroquinolones, that's why we try to hold off on using those as best we can. So that's what I would say about that one. Some said I read online there's such a thing as a carbacephum, and from my understanding, it's a type of antibiotic that has a cephalosporin structure, but a sulfur substitute for a carbon. Since they're a beta-lactam antibiotic as well, could they be used in broad-spectrum empiric treatment of nosocomial pneumonia? Are they better or worse than a regular cephalosporin? I had to do some digging on this. I had not actually heard of that specific chemical classification, so I was looking around, and I found there's one drug called loricarbef, but this was actually, if you look, and maybe text a little small, I know it's probably a little passe to use Wikipedia as my reference here, but it was actually discontinued in 2006. And this is the only one I could find that really fit under this category. And it's not in use anymore. So that's probably why I didn't talk about it, because I was actually, I was just starting pharmacy school that year. So that's why I probably didn't get a whole lot of use of it. Anyway. Someone says, can you please remind me what magnesium does for a patient experiencing status asthmaticus? Yeah. Magnesium is good for helping to relax that bronchial smooth muscle. It kind of works almost like a calcium channel blocker if you think about, I'm talking about like your amlodipines and things like that from last semester. So it relaxes the bronchial smooth muscle and allows for better airway movement, right? Because by relaxing that muscle, you increase the radius, basically the amount of air flowing through the respiratory tract, and that allows for easier breathing. So that's what we're using the magnesium for. We do it a lot for patients who are sick enough to require admission to the hospital. We do it pretty often. Someone says, in a stepwise approach to asthma treatment, it looks like there are no short-acting meds listed after step 2. Wouldn't you still want a short-acting beta-2 agonist or another short-acting med in case of emergencies or when around triggers? Absolutely. Always want to have a short-acting beta agonist. Everyone's going to get that, right? Whether they have persistent or intermittent symptoms, everyone's going to have a short-acting beta agonist on there at a bare minimum. So just, yeah, make sure that's always there, because you never know when those attacks might happen. So you want to make sure they have it available to them. Just like having an EpiPen or something if you have someone with a history of anaphylaxis, for instance. Someone said, in the patient, if your patient has a community-acquired pneumonia, prescribe either beta-lactam plus macrolide or a fluoroquinolone, how come you wouldn't just do either a macrolide or a fluoroquinolone? I just want to make sure I understand why we are choosing these drugs. You don't want to do the macrolide by itself, because you end up seeing a decent amount of resistance to things like H-flu, strep pneumo, and whatnot. So that's why we can't really get away with the macrolide by itself. That's why I have to include something like the high-dose ampicillin or the cephalosporin. So that's why you do that. The fluoroquinolones, while there is a risk for having strep pneumo resistance for sure, and some of the other bugs, it depends on where you're working at, and you can find the different places will have different resistance patterns, and so that's why you have to kind of be more judicious about utilizing that. So that's why I would say probably use the beta-lactam plus a macrolide most frequently. Get away with that. And then save the fluoroquinolones to when you have a good case of, like, you have a culture that came back and shows the bug is sensitive to that, or they have some other competing factor that says, yeah, you should use a fluoroquinolone. I like to hold off on using those if at all possible. All right, because it got overused for a long time. They still are to a degree. The other thing I wanted to talk about real briefly was our prescription assignment. So here is the rubric that I uploaded, and you have 2 weeks to complete this. I think I set it up for next Friday. Yeah, so I think the 12th is when the due date is for this. So notice the first half of the rubric has the normal prescription assignments you guys were used to doing last semester. This first one here is going to be based off of medication order writing that you would do in the hospital setting. So, and again, using handwritten orders in a hospital is probably kind of going the way of the dinosaurs, but it's still good to get practice to understand what is required for an order. So basically, this is the things I'm looking for in terms of the points and whatnot for that. And I think your first one is a pretty straightforward asthma case in terms of medications you're writing for. So you can see an example case here that I put down, and then here's what I wanted to focus on in terms of how you're going to be writing this. So first off, obviously patient information goes on there. Your name will go there as the provider, and then um, information about the hospital or whatever. So this is the big thing I want to get into. So first off, you always have a date and time for your order, so that way we know when in time and space that this actually happened. And then it's always going to be capped off by your signature at the bottom. This way we know that all of this happened at the same exact time. No one's going to go in and try to add stuff onto your orders and get confused and all that. If you're writing all the orders at the same time and date, you don't have to write this multiple times. So just write this once, and this will encapsulate everything you do until you write your signature at the bottom, okay? You don't have to write this in every single box. All right, so here's a couple of different types of orders. So for the first one, let's look at some fluid orders that we have here. So this would be a typical sort of maintenance rate of fluids you would get. Notice the name of the drug is here along with the strength. So D5NS with 20 KCl. Notice the route is present, IV has to be there. And then the dose, in this case here, is actually a fluid rate. So this is the only time you'll typically write things as like mLs. And so you can see here at 125 mLs per hour. No, that's important. It's not per day or per minute, it's per hour in this particular case. And then you can just write continuously. It's fine. You didn't even have to write the continuously, and that would also be fine there. Note, you don't have to put a specific duration on these orders. If you want it to run continuously, it's just going to run continuously until you come back, you or someone else comes back and discontinues that order, okay? Very frequently, most medication orders in the hospital don't have a stop time on them because they have a tendency just to fall off the profile, and then you don't know, patient may stop getting medications that they need. So what happens typically is that you're going to go and see that patient the next day, or whenever you go see them next, and you can reassess whether or not they need all these medications and decide to continue it or discontinue it. So you don't have to worry about durations unless it's very specific. So for instance, if it's you're doing like a drug called Toradol, ketorolac, an IV NSAID, you can only do a max of 5 days of that. So you might put, okay, do this every 6 hours for 5 days. At that point there, you can put a duration on it, and that's fine. Here's an example of a medication we'll talk about a little bit later on. Oh yeah, so I'll talk about that in just a moment, Emily. Here's a medication called lorazepam. We'll get into in the neurology section, but basically, again, you have the drug name. You're putting down the dose that they're going to be getting here, right? Notice you don't have to worry about the concentration. That's something we deal with on the pharmacy side of things. So don't worry about that. So you just need the drug name, the actual dose they're going to get. Notice the route here is put down, IV push, and then they have how often they're going to get. So every 2 hours as needed for anxiety and hallucinations. If you put something as being PRN, you need to put an indication there. So that way the nurse will know when to actually administer that medication. So if they're not having anxiety or hallucinations, you don't worry about giving it, okay? Note here, here's an example of ceftriaxone. The actual time to infuse it is a little different. So notice here, this one, it would be given over 30 minutes. You can specify how fast you want that to be given. If you just put IV, then the nurse may give it as fast or slow as they want. So this may be something you need to look up because some medications need to be given over a long period of time, some over a short period of time. For instance, vancomycin has to be given over at least 2 hours because we don't want to cause red band syndrome, if you recall from last semester when we talked about vancomycin. So if you want to be specific about the duration to give this drug over, then you can put that on there as well, okay? Then you sign it at the bottom, and then you're good to go. So that's basically how these will run. They're pretty straightforward. They're a little bit simpler, I think, than the prescription orders in order to fulfill the requirements. So they're pretty quick to write there. So if you have any, and then you have the blank one here, you can do it at the bottom for your assignment to turn in 2 weeks. So if you have any questions about that, certainly let me know. Someone said, good morning. I was looking at the schedule for the semester and was wondering if our first 2 exams will take place during scheduled class time or Tuesdays. Yeah, so those will take place during that class time, 8 to 9, and then we will meet afterwards. So I'll have a live stream set up for 9 to 10. I believe I put that on. That is scheduled into it. So I'll make sure you guys are aware of that on those weeks and let you know what time we're going to get started for that. So yes, thank you for clarifying that. That should be good to go. Any other questions I can answer for you in the meantime before we get started? Sorry about that. Yeah, so, um, and again, I love you guys putting up questions. That was fantastic to make sure everything's getting clarified there. So always feel free to do that. I don't mind getting interrupted and stopping and switching gears for a minute or two. Even if you have like random questions about drug stuff, I don't mind talking about that either. You know, keeps it interesting for me as well, especially if it's stuff I've never heard of and I get to look it up with you. But, um, all right, so we finished up the pulmonology stuff last time. Let's get into our gastroenterology drugs here. This is a very common set of drugs you're going to be using for all types of patients. A lot of these drugs are over the counter you're going to be using here. A lot of these may be used for more intensive cases as a prescription only basis, but we're going to look at them and get into all the nitty gritty here. But a lot of patients are going to be coming to you complaining of GI issues, and so it's good to know the medications you can use in order to help treat them, basically. So let's start out with GERD drugs here. What is GERD? Well, we're having gastroesophageal reflux. We're getting contents of the stomach being refluxed back into the esophagus. And, you know, the stomach is designed to handle all that stomach acid, right? Because all that hydrochloric acid keeps your stomach at a pH of 2 normally. But it has a nice mucus barrier that protects it from basically digesting itself. The esophagus, not so much. And so you can find, especially with chronic exposure of that, GI secretions in the esophagus, you can lead to erosions, you can lead to perforations in some rare cases. It's not great, right? So we need to find some way we can try to deal with that excess acid that is maybe being refluxed back into the esophagus there. So what we're seeing here is that because of that increased contact time, and normally what we're finding is that there's sort of an imbalance here between both the aggressive factors of the actual acid content of the stomach, but also the defensive factors in a lot of cases are going to be diminished. So we're losing some of these defensive factors. That's leading to the symptoms that we're seeing there. So as an example, normally we don't reflux a lot of contents of the stomach into the esophagus because we have that lower esophageal sphincter. It's a nice tight contraction of that smooth muscle that prevents it from being refluxed back into the esophagus. Well, what if maybe you had relaxation of that lower esophageal sphincter? Let's say, for instance, you had someone with a calcium channel blocker on board that relaxed that muscle. Well, now you have an opening there for the reflux to go into the esophagus. Not great. Or if someone squats down, all of a sudden they have a lot of increase in abdominal pressure. So there's a lot of things here, not only just anatomical, but also due to a lot of it maybe the gastric emptying. Maybe they're not things are not moving out of the stomach as quickly as they should. So a lot of factors that go into this, and certainly medications can play a role causing some issues, and I'll talk about those, just like calcium channel blockers. I'll talk about them as they come up. Basically, though, here is sort of the main players in terms of hormones and things like that are going to be stimulating gastric acid production, and then I'll talk about some of the ways our medications can interrupt this, okay? So a couple of the big players here include things like acetylcholine. Acetylcholine is going to be acting on our muscarinic receptors. I don't care if you know if it's M1 or M3. I don't want to get that granular, but these are muscarinic receptors. So this is part of that parasympathetic nervous system. This will stimulate the proton pump here, and this is what kicks out hydrogen ions to form hydrochloric acid, right? That's the stomach acid, basically. So this is a huge player here. We're going to find some ways we can try to inhibit that proton pump. You may know what I'm referencing there in just a moment. But acetylcholine is one stimulation of this, one stimulant of this process. We have histamine is another big one. Now, we talked about H1 blockers last semester. However, now we're dealing with H2 receptors, so that is important to make that distinction between H1 and H2. H2 is primarily found here in the GI tract. We're also going to have gastrin being another strong stimulant of this process here. And then we will also have prostaglandins. Interestingly enough, these are going to be an inhibitory factor here. Prostaglandins we know to be formed from the actions of cyclooxygenase on that arachidonic acid pathway. If you recall with talking about our ENT drugs, we talked about NSAIDs, that's going to be playing a role here as well. We talked about a lot of the stomach issues that come about from NSAIDs, and it has to do with inhibiting the production of prostaglandins. So we'll talk about that briefly. But these are the big ones. So acetylcholine, histamine, and gastrin are probably the biggest stimulants of gastric acid production you'll see here, right? These parietal cells. Now, what about on the, and I forget to respell this. I spelled mucus wrong, but let's look at the protective factors here. Well, basically, you have these epithelial cells in the stomach You'll notice that both prostaglandins and acetylcholine will stimulate production of both mucus and bicarb. What that does is it provides this kind of mucus barrier around the stomach that prevents the stomach from eating itself, basically, from digesting it. So you'll notice here that it has a nice neutral pH of 7, and then you'll have the gastric lumen pH of around 2. Very important to maintain this balance here. If I have someone who started something like an NSAID, and now all of a sudden I don't have as many of these prostaglandins around, you're going to find that you're not producing as much of this barrier, and that's where you get a lot of NSAID-induced peptic ulcers from, is because of this imbalance between the aggressive factors of the stomach acid and the defensive factors that you can see here. So certainly plenty of risk factors. Some of these may be reversible or modifiable, meaning, you could recommend your patient lose weight or, avoid, ingesting certain foods that are known to aggravate their GERD symptoms, things like that. But we're obviously going to be focusing on the medications a little bit here that can exacerbate this. So a lot of these we've seen already. So things like anticholinergics, so things like your antihistamines, your first generation antihistamine, or sorry, H1 blockers there. Things like narcotics, which we'll talk about later on in the semester, calcium channel blockers, nitrates. So a lot of these things can also aggravate or mimic the symptoms of GERD and still require similar treatment, as we'll see here in just a little bit. So our goals here, try to alleviate or eliminate their symptoms. We can try to maybe reduce the number of episodes that they're going to have. That can be useful. And if they have evidence of injured mucosa, or maybe they have like a history of ulcers or something, we want to be able to promote the healing and prevent any complications like perforations, bleeding, and whatnot. So our options here, obviously lifestyle modifications are super important. Medications can only get you so far, but if the patient is still consuming foods that are aggravating this, or they're not, getting a lot of lifestyle modifications in check, they're going to have limited utility here, right? But basically, we're going to then look at some of our pharmacologic interventions, way we can deal with this. And even in some cases, interventional therapies are needed, like surgery. So this is something I see a lot in kids, where they have to require going into surgery for anatomical issues that they have just as a congenital issue that they develop during their development and whatnot. But I'm not going to get too much into that, obviously. So as I mentioned, in terms of lifestyle modifications, this goes hand in hand with the medications. And so if they're not going to do any of these, then the medications are going to have limited utility. But obviously things like weight loss, elevating the head of the bed, that way just gravity helps keep some of that gastric content down. Looking at their dietary changes. If they say, man, I always get GERD symptoms every time I eat this really spicy curry, whatever spicy food you want to insert there. They're like, well, stop eating that food, you wouldn't have GERD symptoms. But they may not want to do that. Maybe they really enjoy that food. Things like that. So these are all things that I'd certainly recommend to your patients there. But I want to get into the medications. That's what I'm going to be focusing on. First off, we're going to look at our antacids. We're going to look at our H2 receptor antagonists, our proton pump inhibitors, prokinetics, and then a few mucosal protectant drugs. So there's a couple of ways we can deal with the acid that your stomach is producing, and you can probably guess a few of them just based off of that diagrams that I was showing before. We can try to neutralize the excess acid. We can try to reduce the amount of acid being produced, or we can try to enhance the gastric mucus defense. Okay, look at some ways we can deal with that. So first off, I want to talk about neutralizing that excess acid and see what we can do here. This is mainly going to include our antacids. Basically, this is a pretty simple chemical reaction. This is just like neutralizing anything else. You're going to be putting in a basic drug with a acidic solution of the stomach, and they neutralize one another. We're going to find there's some differences in terms of palatability and solubility and things like that. So we'll look at some issues that drive from that. Main ones you're going to run into, and if you have nightmares of chemistry from back in the day, I'm sorry if I cause you any duress, but got food around here. But this is basically what's happening here. So if you imagine here, we have our four main antacids. We have sodium bicarbonate. I would not. Okay. Don't use sodium hydroxide as a antacid. You will probably melt your patient's stomach and cause them to die. That's actually drain cleaner. So that was a big mistake on my part. Not sodium hydroxide. That's bad. That's not great for antacid use. Sodium bicarbonate, though, is good. This is like baking soda. This is reasonable. So you have sodium bicarbonate. You have calcium carbonate here. You have aluminum hydroxide, and you have magnesium hydroxide. These are your four main antacids there. You will find that when they combine with the stomach acid or the HCl that's in there, that you're going to get basically these reactions happening, which makes sense. You recall this when you neutralize an acid with a base, you're going to get heat and you're going to get carbon dioxide most frequently, and water formed here. So you'll have sodium chloride, water, and carbon dioxide. Now, when you think about adverse reactions here, what do you think all that extra CO2 is going to be doing? They're sitting in the stomach. That's extra gas. It has to go somewhere. Probably going to cause some belching. It may cause flatulence, things like that. So you can kind of intuit some of the side effects that happen from these drugs just looking at the reactions that they are involved in. So it's kind of neat. First off, starting with sodium bicarbonate or baking soda, this one will quickly neutralize that acid. And I mean, people go like, you mean like the baking soda you can find in your pantry? Yes, this works exactly the same, but we have some tablet forms of this, but it's all the same stuff basically. Not that I would recommend your patient going in and start, just getting spoonfuls of the stuff, but technically it would work. Problem though is that it does have a big sodium load associated with it. So if you have patients with a history of hypertension, for instance, this may not be great because it's going to lead to fluid retention, increase in blood pressure potentially. So this will have some limited utility here. Also, it produces that gas, as I mentioned, which may not be great from a side effect profile. You'll typically find too that the antacids are limited in utility because of the fact that by neutralizing the acid in the stomach detects that increase in pH and it says, oh, I should probably produce more acid to get this pH back down. So what does it do? Well, you release more gastrin to try to produce more stomach acid. So it kind of is self-defeating in a little, in a sense, where you're giving the antacid, but you're also producing more acid as a result of that. So antacids in general are better for sort of like episodic, short, immediate relief sort of GERD symptoms. This is not going to be for the long haul because overall they're going to have limited utility. The patients have to take them constantly throughout the day. It's not really great. But if it's like someone who is like, oh yeah, I went to my favorite Mexican restaurant and I had too many margaritas and some spicy, I don't know, chimichangas. Yeah, that would work. You could use it for that very acute episode of GERD as a result of that one episode, right? Again, I don't mean to vilify any spicy foods. I love all spicy foods equally, but those are a common culprit for causing GERD symptoms. But anyway, so you kind of get the idea there. This is not for like long-term maintenance of acid reduction, basically. Calcium carbonate is probably the most common one you're going to run into. This is like your typical Tums that you think about. This one has fairly good neutralizing capability here, works pretty quickly. However, keep in mind you will have some absorption of this calcium, which may not be great for patients who have, like, for instance, a history of kidney stones, right? And again, as I mentioned, you have that rebound acid secretion you'll see there. Some of the problems you're going to run into with these patients is that calcium carbonate can cause constipation. And so for a lot of these older patients too, if you think about it, well, they probably need calcium because you worry about osteoporosis. But a lot of the medications they're taking can cause constipation. If they're on opioid medications, if they're on calcium channel blockers, if they're on lots of things that can slow down the GI tract, this is going to worsen that. So that may be an unintended consequence of your calcium carbonate that is maybe not all that tolerable by your patient. And again, all these antacids are available over the counter, so patients have access to these without consulting a provider. So it's important that you ask these patients when you see them, what are you taking? What are you taking that you can get without a prescription? Because if you don't recognize this, you can lead to a lot of drug interactions. You're going to find, particularly with calcium here and a lot of other antacids like aluminum, these will bind to other medications in the GI tract. It's a big drug-drug interaction you run into. So if someone was taking a fluoroquinolone for pneumonia, for instance, this can bind up with that calcium and prevent the fluoroquinolone from being absorbed. Not great, because then all of a sudden your antibiotic is not going to be working as well. You're trying to figure out why that's the case. Lumen hydroxide or Amphigel. Now, by itself, this is typically used for patients with renal disease, and I'll talk about this later in the semester, but more often than not, you'll see this used in combination with magnesium hydroxide. I'll talk about why that is in a moment. We use it by itself to actually decrease phosphate absorption, which is a problem with patients with renal disease. They've developed hyperphosphatemia. But similar effects as you're going to see with the other antacids here. Again, it can chelate to other drugs, just like with the calcium carbonate, so it can bind those other medications and prevent them from being absorbed This one also is going to have some constipating effects as well. They actually found it's contraindicated appendicitis because it has a tendency to aggravate that. So, and again, patients may be taking these medications to mask the symptoms of other things. Maybe they're having stomach pain and they think it's GERD, when really it could be a case of appendicitis. So, one thing you'd want to avoid there. And then we have magnesium hydroxide or milk of magnesia. This one is pretty well known to cause diarrhea, and in fact, used by itself, which we'll talk about later, is used for constipation. So what we frequently though see is that you're going to have a combination of magnesium hydroxide and aluminum hydroxide together. So if you ever see like a Malox or Mylanta type product, that's the combo of aluminum and magnesium hydroxide. The benefit there is that while magnesium hydroxide causes diarrhea, aluminum hydroxide causes constipation. So they sort of cancel each other out to a degree. There's a funny bit on The Simpsons from back in the day where Homer has a lobster and he's trying to take care of this lobster at home, and so he puts it into a an aquarium style container full of regular water, and so the lobster starts to die. So then he starts to pour salt in it to make it salt water, and then he gets too much and the thing sinks to the bottom, so then he puts more regular water in. So he's trying to find this balance here between where the lobster will kind of float there in the middle. So that's kind of what you're doing here, is you're canceling out the effects of one drug with the other, hopefully having a neutral sort of effect there. You can look up that video. I promise it's funnier than how I described it. Magnesium hydroxide, also not great for patients with renal failure because they may already have hypermagnesemia to begin with. And if they have an intestinal obstruction, you don't want to have anything that's going to try to increase flow through the GI tract because that can worsen the obstruction. So you'd want to avoid that there. As I mentioned, you'll find these two together most frequently. So that's a lot of your over-the-counter products like Mylanta, Malox. And frequently you'll find that we like the liquid products a little bit better because it does have a nice sort of coating effect on the stomach. Aluminum has a little bit of that cytoprotective effect we talk about, so that's why we typically go with that. But it's kind of like chalky kind of flavor and texture to it, so people may not like that, so tablets are available. So problem with the antacids is that a lot of times patients may be masking worsening disease. They could have an ulcer that's sitting there due to something like H. pylori or an NSAID, but they're just treating the symptoms. You're going to realize that things can be getting worse behind the scenes and them not really realizing it. So that's why a lot of the documentation about antacids, if you go and look at them at the drugstore, you'll see that it says don't use for more than 2 weeks or something like that, or consult a medical provider. Symptoms continue beyond 2 weeks, because you want to make sure that you're, as a provider, ruling out the more scary stuff that's going on, that they're not just treating the symptoms thereof, okay? Typically, these are pretty safe in pregnancy, and we'll talk more about these. We'll talk more about pregnancy in the OB-GYN section later on. We definitely want to avoid using sodium bicarb for those pregnant patients because you can worsen the hypertension. Preeclampsia can be an issue for them. Be aware of that. And especially the calcium and aluminum can bind up a lot of other oral drugs. So what I would say is, if you have a patient who needs to take 2 interacting medications, say iron or fluoroquinolone, have them take one of these drugs an hour before the antacid or 3 to 4 hours after the antacid. That way the two are unlikely to meet in the GI tract and cause an issue in terms of absorption. Important to note that, because you'll have lower levels of these drugs because they're being bound up in the GI tract and not being absorbed. Another thing you may see used occasionally, this is pretty limited utility, but it's available in a lot of over-the-counter products. It's called Alginic Acid. And this actually reacts with sodium bicarb to form this like really viscous solution. So it kind of helps to coat the stomach and kind of protect it from the stomach acid, but really limited utility here, but you'll see it used occasionally. So here's an example of Gaviscon, which normally has an antacid plus this alginic acid plus bicarb. Again, they may try it. Some people may get some relief out of it, but I would not hang my hat on it too much. So overall, what are the advantages of antacids? They have quick relief. They're going to have pretty much the most rapid onset of action because it's a very quick chemical reaction that's happening there. They're inexpensive. A lot of them are available OTC. You get them without a prescription, which is great. And these are typically used for very intermittent cases of GERD or for like breakthrough cases of GERD. So say they're taking something else that's more long acting, but they have like a breakthrough because they had too much food at one meal. This is good for that breakthrough sort of symptoms. In terms of disadvantages, not good for healing if they have damaged tissue due to GERD. Oftentimes they're required to be dosed multiple times throughout the day. Drug interactions, you got to worry with the constipating versus the diarrhea effects, depending on which one you're talking about. So just be aware of that, which drug you're talking about and which effects they can actually cause. Okay. So let's then switch gears. Let's talk about how ways we can reduce gastric acid secretion. This will be the biggest group we'll talk about here today in terms of drug categories. So first off, let's look at our H2 receptor antagonists. Basically, by blocking these receptors here, you're going to be overall reducing the amount of stomach acid being produced at the proton pump. Note that you still have other means of producing acids. You still have acetylcholine, you still have gastrin, but this is a major inhibitor here by removing histamine from the equation. So overall, you're going to see that this can get more sort of long-term consistent reduction in stomach acid production because you're able to have a drug that's sitting around all the time, blocking the histamine production. You don't get any kind of like rebound increase in gastrin, or even if you did to some degree, it's still going to be inhibited because that histamine is still sitting there preventing histamine from interacting with those receptors. So overall, better for sort of like long-term sort of control, or if someone had more persistent symptoms throughout the day, this is going to be better for that, right? And this is a set of drugs been around for a really long time. And so we have a lot of good use with these and experience with them for the most part. So I wanted to update this in real time for you. So this is actually something that happened this past year in 2020. We actually had taken off ranitidine from the market. Interestingly enough, ranitidine was a really good drug, and it was the one that I used most frequently for my patients. But it was actually found that if the product was stored at a high temperature, which you can imagine, maybe not today in Florida, but certainly in the summertime, it could actually break down into a product that had was a known carcinogen. And so this is something that was only recently discovered, so it actually got removed from the market. So we have 3 other ones that you can use here instead. So we have cimetidine, you have famotidine, and then nizatidine. And again, they're basically just blocking those H2 receptors, preventing histamine from interacting with it. So these are all going to be well absorbed from the GI tract. They do get renal secretion, so you do want to watch renal function. I've seen a lot of providers not even think about this when they're reviewing a patient's medication profile, but definitely adjust the dose based on renal function, especially over time if patients are using these for years and years. In terms of like side effects, there's really not a whole ton that happen here. Again, this is stuff that's reported, but honestly, I don't know if I've ever really run into too many issues of patients having side effects related to the H2 blockers. But these are things that can happen. They're just pretty rare. So these are pretty effective in the majority of patients here. I would definitely say in terms of efficacy in the grand pantheon of GERD drugs, these are certainly going to be a step up from the antacids, and they're also better for sort of long-term throughout the day sort of control here. And they're going to be a little more expensive than the antacids, but they'll be kind of second, in terms of most affordable out of the bunch here. And most of these are available over the counter, so patients may be self-treating with these as well. These are also very safe during pregnancy, so not have any qualms with, say, for instance, pregnant family member or something like this taking one of these H2 blockers. Very safe from that standpoint. You'll typically see, and again, you can see this if you're looking at like OTC recommendations versus prescription recommendations. They will typically use lower doses OTC than what you may be prescribing, and they usually limit it to 14 days just so patients are not really covering something more serious that could be going on that needs to be diagnosed by a provider such as yourself. Most patients will either use these on like a daily basis. I mean, take it once, twice daily for sort of around the clock coverage. Some patients will do this, say, as like a pre-medication. So if they know that certain foods will trigger their GERD symptoms, then they can take this as a prophylactic beforehand. Or that once they're having symptoms, they can use it, but it's not going to have as quick a relief as the antacids will. So that's one kind of downside from that standpoint. And in terms of drug interactions, this is a big one here. And this is why I usually never recommend cimetidine. I would recommend that you never recommend it either, because CYP3A4 is going to be strongly inhibited by cimetidine. So this is something people can get over the counter and can really get themselves into trouble if no one tells them, hey, don't take this along with your XYZ medication. Don't take this with your simvastatin, right? So I've seen several patients get into trouble with this, and so I always tell all my students, never, ever, ever recommend cimetidine, because it's just no reason to use this one over the other agents we have available. and none of the other ones have this strong CYP3A4 inhibition. So just don't do it. The next group we have here are going to be the proton pumps inhibitors. And so again, instead of just trying to monkey around with all these sort of receptors here on the surface of the parietal cell, let's just go to the source. Let's just stop the proton pump from working altogether. So you can block it right here and prevent the actual protons from being secreted out into the lumen. And so that's going to be pretty effective. And this is going to be one of the best ways we have to stop acid production in its tracks. What's cool too is that these drugs are going to be irreversible inhibitors, meaning once this pump is inhibited, it's inhibited for the lifetime of that pump. And so until it gets metabolized and a new one is produced, it is just not going to produce any more acid. So you can get really strong suppression of acid secretion, especially if they're taking it consistently, for several days in a row. You get like 95% inhibition of these pumps here. So very, very effective at what they do. There's several available here. A lot of these have become over the counter over the past couple of years. So you'll see many of these available for patients to use themselves. But we have things like esomeprazole, lansoprazole, omeprazole, pantoprazole, and then rabeprazole. So you can really tell if it has a prazole at the end of the name, then you can tell it's going to be a proton pump inhibitor. Not a ton in terms of adverse effects. Some people worry that there is some issues in terms of causing hyperplasia of these parietal cells, mainly because of the fact that you can, by inhibiting this acid production, you can have a lot of stimulation of gastrin release. Even though it really won't be that effective because all the proton pumps are inhibited, there is some concern about hyperplasia and, remote cancer risk, but it's not enough to really recommend not using it for your patients there. Other things you can run into, though, is that typically you'll find that in the stomach, it's a sterile environment because that pH is such that really no bacteria can grow, aside from something like H. pylori, for instance. So what you run into is that when you have patients who have elevated pHs there due to a proton pump inhibitor, you could risk things like infection. And again, not just like a stomach infection necessarily, but you can have those bacteria that can translocate into the respiratory tract. So I've seen cases of pneumonia secondary to use of a proton pump inhibitor, right? Also, you're going to find things like calcium tend to be better absorbed at acidic pHs. So if I raise the pH up pretty significantly with the PPI, you're going to find that that can actually lead to calcium not being absorbed as well. And so you can see hypocalcemia. This could be bad for patients with risk for osteoporosis. It could induce osteoporosis in some patients, if they're using this for months and years. So just something to consider there as well as a calcium issue. Calcium will not be absorbed as well here. You definitely want to make sure you're administering these about 30 minutes before meals because that's when the proton pumps are going to be most active. And this is these drugs require active pumps for them to work. They don't work on inactive pumps. We also recommend that you don't crush or chew these. And so frequently you'll find these come in capsules. If you look at them, they have all these little tiny beads inside of it. And basically, the drugs themselves, they get destroyed in an acidic environment. And so those little beads have a coating on them that are acid stable. But when they get into the small intestine, they at a more basic pH, they actually melt away and allow the drug to be absorbed. If you have patients who chew these up or crush them, they actually will break that coating and then will allow for the patient to basically destroy the drug before it becomes effective. So that's why we tell them don't crush or chew these. And then overall, in terms of efficacy, you'll find these going to be a step up above the H2 blocker. Very good in terms of helping out with healing for an erosive esophagus or a stomach ulcer, things like that. So just be so these are very effective, usually a little bit more expensive, but very good drugs overall. In terms of adverse effects, again, these are really well tolerated. I really don't run into a whole lot of issues with these, other than sort of long-term concerns in terms of like calcium absorption and some of the bacterial concerns there. So you can have some drug interactions, things like ketoconazole, itraconazole. These are some antifungal drugs and iron salts. You may find that the PPIs are not absorbed quite as well. Eric was saying, do you dissolve these on your tongue or do you swallow them like a pill? So there's a couple options there. Most of them are going to come as a capsule that you can just swallow. And actually, you can open up the capsule and put those little beads into applesauce or pudding or something like that, and they can take it that way. That's no problem. Just something they're not going to chew. But there's a few dosage forms that are out there. So like lansoprazole has a solutab, so that one could be absorbed buccally basically. A lot of the tabs dissolve in the mouth. So it depends on the dosage form. But for the most part, you want to prevent the actual PPI from coming into direct contact with the stomach acid because it does not, they don't play well together. They don't like, they will destroy the drug basically. Very good question. And so again, just to reiterate the point here is that a lot of these are available over the counter nowadays. So like omeprazole is the first one to go OTC. You got to warn these patients on what to watch for if they're going to use these to self-medicate, because the problem is that they could be masking some really bad stuff. So for instance, like they need to know if you have bloody or black stools, that's not a great sign, right? They could have melena, and that could be evidence of an upper GI bleed that they are masking the symptoms of with these PPIs. Other things to look for, if they're having things like, they're feeling lightheaded or dizzy, if they're having unexplained weight loss, and all these things that may not seem related to GERD, but things that could be indicative of something much more serious. So this is why they recommend not using these for more than 2 weeks OTC, even though you may be prescribing these for patients to take them for years, but it's because now they've seen you've ruled out all the scary stuff, and they are safe to take these as opposed to they're just medicating themselves. So just something to think about. And again, obviously, we'll tell them, for instance, if their heartburn continues beyond this 2 weeks, if it gets worse, if it returns right after you stop therapy, like this is when we want to recommend they come in and consult a provider in order to get a better workup than just a patient reading WebMD and then treating themselves, basically, right? So those are the mainstays that they're your antacids, H2 blockers, PPIs. Those are like the most common ones here. Here's an example of a drug you use occasionally, one called octreotide. This is actually an analog of a hormone you produce called somatostatin, but it actually works to block release of gastrin. So we will use this in the hospital setting. It's only available parenterally, but you can use it for cases where you have like hypergastrinemia. So if like a tumor that was releasing a lot of gastrin, some of these hypersecretory conditions like Zollinger-Ellison, things like that you can use to help decrease acid production as a result of gastrin. So some other fringe cases for using octreotide, but this is the main case we're going to see being used. So finally, we've looked at ways to neutralize the acid. We looked at ways to reduce the production of the acid. Let's look at some ways we can actually protect the actual mucosal tissue itself. First off, we have Pepto-Bismol or colloidal bismuth. You'll usually see this. I have a sneeze coming on. I feel like I have a sneeze coming on, and if I think really hard about it, then all of a sudden the sneeze goes away, only to come back a few minutes later. So I might have to start and stuff like this a few times, so I apologize. Anyway, so if you see like Pepto-Bismol over the counter or something, you'll see that it's called bismuth subsalicylate. That's the generic name for it, basically. And so Pepto is good because it actually works sort of to coat the stomach and kind of helps enhance that mucus barrier your stomach produces anyway, and also helps to like inhibit some pepsin activity. So pretty good. We use this a lot for like, traveler's diarrhea and things like that. This is a good component of treatment for H. pylori. So you'll certainly see some good effects from it. But some things to be wary of is, one, it can impart sort of a black color to the oral cavity or the feces. That's important to make sure patients know about, because if they see black feces, I'd be certainly concerned about an upper GI bleed. So they need to know that this is a normal effect that's related to the Pepto, right? Also, because it's called bismuth subsalicylate, contains salicylate. So if you recall back when we talked about ENT stuff, that you do not want to use salicylates in kids less than 16, especially if they have, if they have a recent history of viral illness, because you worry about Ray's syndrome risk. And so there are rare cases of Pepto-Bismol actually inducing Ray's syndrome for those patients there. So again, that same caveat applies to this, just like it would with aspirin. Another mucosal protectant is going to be sucralfate or carafate. This is basically when carafate gets in combination with an acid, it makes a very thick sort of paste that helps to protect the stomach and help to coat it. This is used more so like in really mild cases of GERD. It's a little bit more expensive too, so I find it has limited utility as compared to something like an H2 blocker or PPI, but maybe it could be useful in addition to those drugs as well. Other things we can do and also include replacing the prostaglandins maybe those patients are missing. So this is really good for patients who have an NSAID-induced ulcer, Well, let's replace those prostaglandins they're not making anymore. So we have a drug here called misoprostol or Cytotec. This is basically an analog of PGE1. And so this is going to work on those epithelial cells to help produce more mucus and bicarb, and it will help to decrease acid production as well. If you recall, on those parietal cells, they have a spot there for prostaglandin to inhibit the proton pump there. So mostly these are going to be used in patients who have to take an NSAID for other reasons, and they are unable to find, they have a risk of peptic ulcers or they've had a history of it. So this is where we introduce misoprostol for that. This is actually a case though where you want to be really careful on who you're going to use this in. So we actually do not want to use this in pregnancy. This is what we call a category X drug, meaning you never ever use it in pregnancy because it actually will stimulate uterine contractions and can lead to premature labor. And in fact, this drug is also called what we mentioned as an abortifacient, meaning it can actually induce an abortion. And interestingly enough, we actually also use prostaglandins for patients having delay or prolonged labor. You can actually use this prostaglandin type drugs on the cervix to try to help with the ripening and get ready for labor to occur. So from a GI standpoint, not good for pregnant patients, but when used appropriately, they can be useful to help a baby who's maybe not wanting to leave the womb just yet. So we'll talk more about that when we get to OB-GYN later on, though. So this is kind of a handy sort of comparison here between the different classes of drugs. You kind of see in terms of like onset of relief, antacids are going to be the fastest and also the cheapest. In terms of duration of action, they're going to be the shortest and not really good for like long-term healing of damaged mucosa. Your H2 blockers, your PPIs are going to be better for long-term sort of treatment for more persistent symptoms, for healing of eroded tissue. These two classes are going to be the best here. PPIs are going to be better than your H2 blockers, but maybe more expensive. So there may be some pluses and minuses between the two. Certainly for more severe cases, we're just going to go with the PPI. So any questions on that so far? All right, we continue on. So more anti-emetic drugs here. So basically, we're going to use this for any cases where a patient's having nausea, vomiting, whether it's they're on a cruise ship and they're having some vestibular disturbances leading to motion sickness, whether they're just had surgery and are nauseous after receiving anesthesia, if they're, getting chemotherapy for cancer and they need to treat nausea, vomiting associated with that. These are all going to be drugs used to treat any of these. See, some are a little bit better than others, but they're all going to be very handy here. So I'm going to try to resize here a little bit of this. So basically what you're going to find is that there's a pretty complex interplay here between various parts of the CNS and the GI tract. They're going to help to basically mediate these vomiting reflexes we see here. So basically you can have receptors here located directly in the stomach and in the GI tract that can induce nausea, vomiting. So just as a shorthand, if you see 5-HT3, that is a shorthand for serotonin. It stands for 5-hydroxytryptamine. That is serotonin. See D, that stands for dopamine, which we'll talk about more in detail in a little bit. But basically, you can see there's all these different tracks here that happen, and ultimately, it's going to all converge upon the vomiting center in the medulla. That's what ultimately causes the reflexes that lead to you expelling your contents from your mouth, right? There's also going to be what we call the chemoreceptor trigger zone. So this is important for a lot of like direct irritation by certain substances and like chemotherapy drugs, for instance. And so there's a lot of receptors here we can interact with and try to block potentially in order to prevent the signal from reaching the vomiting center and hopefully reduce that nausea they're experiencing and prevent them from vomiting if possible. So let's start out with our first group here of antiemetic drugs. Here's where we're talking about antimuscarinic and antihistaminic drugs. A lot of these we've already talked about, fortunately, when we talked about ENT drugs, when we get to the H1 blockers here. But in terms of like pure antimuscarinic activity, so if you look back here, you can see by blocking M1 receptors, you can see in several places here, you can reduce nausea and vomiting. You also are going to find that this is really important. Acetylcholine and muscarinic receptors, very important in terms of vestibular responses here. So if you have someone who is going on a cruise ship, for instance, on this really big boat, the boat's moving, right? It's not stationary when it's out there in the water, but to the person, it may appear that everything is stationary because to their perspective, everything is staying the same because they're on a big boat, so they can't see all the waves and stuff. So what happens is because they're having that movement there, their body is sensing in the vestibular apparatus, but their eyes don't see it. And when you have that mismatch, this happens a lot with like, I'm big into video games, so like people who are utilizing like virtual reality headsets, because there's a disconnect between what their eyes are seeing, what their ears are feeling, they develop motion sickness. And so blocking muscarinic receptors is going to be a big way we can help to limit that. And so the one we think about most commonly is going to be scopolamine. Typically, you'll see this as a transdermal patch. So transderm scope is pretty frequently used there. And so this is a patch you can actually just put right behind the ear, and it works for about 3 days or so. So if they're going on a 3-day cruise to the Bahamas, guess what? It's going to be perfect for that period of time there. And again, once you put it on there, they don't have to think about it for another 3 days. So it can be good from a compliance standpoint. Really good for motion sickness. You won't see it used for a lot of other types of nausea and vomiting for the most part, but definitely motion sickness, this is great. Keep in mind, though, like what are common anticholinergic side effects, right? So we always talk about anticholinergic side effects in terms of the mnemonic. I'm not sure if I've gone over this with you before, but there's a handy mnemonic we use here. So there is blind as a bat, meaning that they have mydriasis and can have impaired accommodations. They get blurry vision. They can be red as a beet, meaning anticholinergic drugs can cause cutaneous vasodilation and flushing. They can be hot as Hades, meaning they can develop hyperthermia. They will be dry as a bone, meaning that it will have decreased mucus secretion, so they will have dry mouth, urinary retention, constipation, and they'll be mad as a hatter, meaning they can have sedation at low doses, but certainly changes in mental status, hallucinations, seizures, even at very high doses. Those 5 are the kind of the big anticholinergic effects you're going to expect to see. And then also tachycardia is another common one as well. So what this means is that patients, for instance, who have a history of like BPH or something where they have issues with urination, anticholinergic drugs can cause urinary retention and may worsen that, for instance, right? Dry mouth may be worsened here, which may not be all that pleasant to the patient's experience, So things like that to consider there in terms of anticholinergic side effects. This is a big thing. Anytime you're using a transdermal product where the patient's hands may have come in contact with the drug, make sure they wash their hands really well. Here's an example of a lady who came in. Let me it's late. I guess I should not assume their gender, but this person who came in, and if you saw something like this, if you saw a unilateral mydriasis, you might assume they've had a brain bleed somewhere, and you might be quite concerned for that patient. However, everything else was normal with them in terms of mental status and neuro exam. It was just this one eye was mydriatic. And so what had happened was that the patient basically had rubbed their eye after applying a transderm scope and then has this unilateral mydriasis happening here. So basically they get anticholinergic effect in the one eye where they rubbed it. The other eye is spared the effect there. So kind of interesting little unique side effect you can see with that. That's why we tell them wash their hands. So looking at our agents here that fit into the sort of antihistaminic sort of property or anticholinergic category here, we have things like dimenhydrinate or Dramamine. We have meclizine. A lot of these are available over the counter, for instance, which I'm not going to ask you specifically on the test which ones are prescription over the counter, but just for your edification there. Hydroxyzine, which is another common one we use here, not to be confused with hydralazine, which we talked about in the cardiovascular section last year. Yeah, back in 2020. We have diphenhydramine, which we all should be pretty familiar with. And then a couple of new ones, which are more so focused on the anti-muscarinic side of things, include glycopyrrolate or Robenol. We use this a lot for patients with chronic drooling issues, especially like young kids with different like congenital diseases and things like that. They may have issues with like drooling. And so we can use glycopyrrolate for that. And then hyoscyamine is a good one for abdominal cramping. So we use this in the ER all the time. To see if patients coming with abdominal pain can be relieved of their symptoms. And if it's abdominal cramping, hyoscyamine will work pretty well for that. So be aware the most common side effects you're going into, those ones that I mentioned just a moment ago, but also sedation is fairly common. So if someone needs to like go out and drive, for instance, this may not be a great set of drugs to use for them. Typically, you'll find that just the pure anticholinergic, like the transdermoscope or scopolamine, a little less sedating than the antihistaminic drugs. So for instance, that's why they like transdermoscope for like going onto a cruise, because you're going on vacation, which is something you guys may not be familiar with, but back before the pandemic, we used to go on vacations, and cruise ships were a thing. Not to say that they were ever not disease pits anyway, but you probably don't want to be asleep in your cabin the whole time, and so that's why scopolamine is a better option in that case there. But a lot of these are going to be very sedating, which may not be a problem if they're nauseous and about to go to bed, but maybe a problem if they need to go to work or school or something. Okay, next we have antiserotonergic drugs. So these are going to be a set of drugs that specifically block the 5-HT3 receptor. You're going to find in terms of serotonin, we're going to talk a lot about serotonin this semester, but basically there's a lot of different subtypes of receptors here. So this is the first one we're running into. So we have 5-HT3. And basically by blocking these receptors here, you can block it both locally at the stomach aspect. So if you had something directly irritating here, also up in the chemoreceptor trigger zone and elsewhere. By blocking these receptors here, it's a very potent anti-emetic drug. And so this includes the perennial favorite, ondansetron or Zofran, runs like water in ERs and urgent cares across the nation. Less commonly used, you'll see dilaceron and granisetron. And so again, these basically work to block 5-HT3, and that helps to alleviate a lot of that nausea, vomiting. These are pretty effective for almost any type of nausea, vomiting, so we use it all the time. They're also non-sedating, so it's a huge benefit of these drugs over the antihistaminic drugs, like we saw in the last slide. So this is why most people, especially if they're coming to an ER urgent care, they're going to get some Zofran because it's non-sedating. If they're getting chemotherapy, which is known to cause a lot of nausea, vomiting, these are really good drugs for that too. Only downsides, I mean, these are super well tolerated and most people can get these no problem. One thing to note though, and there's actually a black box warning associated with this, or at least an FDA warning, is with QT prolongation. So this is something to where it probably is not going to be a problem on its own. 99.9% of patients can probably get this without an issue. It's the patients who have pre-existing QT prolongation or those that are on multiple medications that can prolong QT. This is where you run into problems. So would I want to give this plus, azithromycin? I might be a little concerned about that, right? Because I'm starting to have 2 medications of prolonging QT. Maybe you want to check a baseline EKG just to double check, right? Probably not going to be an issue, but the issue comes in when they're on 3 or 4 or 5, 6 medications, and you can see that with patients who are getting chemotherapy and things like that. So clinically important, but for the run-of-the-mill patient, probably not going to be an issue. Next, we have our antidopaminergic. So now focusing on blocking D2 receptors, going to be seen here in the chemoreceptor trigger zone and the solitary tract nucleus. These are the main places you're going to see dopamine affecting this. These are blocking D2 receptors specifically. And so this is something we'll talk a lot about in the both neuro, and we'll talk about this in behavioral health a little bit later on. But basically by blocking D2 receptors, you can relieve nausea and vomiting. So the main one you're going to see here used for this purpose is metoclopramide or Reglan. And then there's also several different drugs that fit in this category called phenothiazines that include things like prochlorperazine, haloperidol, and promethazine. These are going to come up more so in the psych section coming up in a little bit later on. But all of these have good anti-emetic actions. Problem though is you're going to find there's a lot of sedation associated with these. These not only block D2 receptors, but they also block acetylcholine receptors as well. So they can have some strong sedating effects. And so, again, if they need to go drive a car, this is probably not the set of drugs to use for them because it's pretty sedating. But if it's like, they just went through surgery and they're, waking up and they're nauseous, they can probably get this as no problem because they're probably going to go to a inpatient bed anyway, for instance. So just something to consider. The big downside that's unique to this set of drugs here is because they block dopamine, they can actually induce Parkinson's-like side effects. We'll talk much more about that in later classes, but just to know that these drugs, because they're blocking dopamine, you can get Parkinson-like side effects, which can lead to things like hyperprolactinemia, can lead to issues of menstruation problems. It can lead to gynecomastia, and also more severely something called neuroleptic malignant syndrome. Don't worry about that now. I'm going to talk about it later in the psych section coming up later on. All right. Next, we have our cannabinoids. So this is a pretty interesting set here. I'll talk about medical marijuana more specifically a little bit later on, but cannabinoids refers to anything that can activate the cannabinoid receptors that we ourselves possess. So there's two main ones, CB1 and CB2. We're mainly going to focus on the activity of CB1 here because that's where the antiemetic action comes into play. But, for a long time, we couldn't use medical marijuana. It was just federally regulated, and the states were not allowing for medical marijuana use. And so instead, what they did was they came up with a synthetic form of the main psychoactive component of cannabis. So and again, you can get into thousands of different chemicals that are present in the marijuana plant, but the main one that causes the high, the euphoria, the munchies, this is delta 9 tetrahydrocannabinol, or delta 9 THC. So we have synthetic forms that we have now made to use as medical products, and this was really used before medical marijuana was more readily available in many states. So we have dronabinol and the nabilone are the two main ones here. These are not used for like routine run-of-the-mill nausea vomiting, but these are more so used for things like nausea vomiting associated with chemotherapy. Thing that used pretty commonly. The other cool thing about this as well is that everyone thinks about the munchies that you get when utilizing marijuana. We can use that for a good thing here. So a lot of patients who have terminal illnesses or illnesses where they are just really feeling miserable all the time, like receiving chemotherapy, or if they have say later stage conditions where they have like muscle wasting, like AIDS, for instance. A lot of those patients feel so miserable they just don't want to eat, and so they start to lose weight, and that can lead to deterioration of their health. So by giving this, it can stimulate their appetite, and they can actually put weight back on. So you can see this used pretty often for that particular purpose. The appetite stimulant, some nausea vomiting treatment, those are the main things you'll see these synthetic THCs be used for. However, because it is a psychoactive component of THC, or a psychoactive component of marijuana, you're gonna see those same effects there. So you can see things like euphoria, you can see memory impairment, all that sort of thing there. Be aware also that they're gonna have impaired decision making potentially. So this is not something I'd want someone to be driving while taking, as an example. So many of these, you can see they have sort of negative consequences in terms of like being able to concentrate and do things that require it, like driving a vehicle. That's where really the anti-serotonergic drugs like Zofran, that's why we like those so much, because they lack all of those sedating effects. Another class here that's more specialized is going to be a prepotent or emend. This is what we call a substance P antagonist. Normally, substance P, you think about like spicy peppers inducing substance P release and causing pain. By blocking this, you can actually also help to reduce the emetogenesis of a lot of chemotherapeutic agents. When we get into oncology, we'll talk about these, but basically, we use these for the most highly emetogenic chemotherapy drugs, and a lot of them are emetogenic, but for the worst of the worst, things like cisplatin, you're going to find that patients may have both an acute phase where they're having nausea, vomiting, but a lot of them will end up having a delayed phase, like 2 or 3 days out. And so this is where something like Amend or Prepotent can be utilized in order to help prevent those delayed phase nausea, vomiting, 2 or 3 days out. And so basically they're blocking this natural product or this receptor called NK1. They're preventing substance P from interacting with it, basically. And so this is mainly just used for chemotherapy. So that's the main place you're going to see it used. This is not for like run-of-the-mill nausea, vomiting. Just be aware this does interact with CYP3A4 and will inhibit it. So you may have to adjust other medications based off of that. And it also induces CYP2C9. So just be aware of some interactions there. You have an issue with warfarin. I'm sure that probably doesn't come up too often, but just be aware of those interactions. Some other things you can see used occasionally, especially with nausea, vomiting associated with chemo, because we know chemotherapy is so frequently associated with nausea, vomiting. We have lots of agents to use to treat that. This can include corticosteroids. We've talked about these before in terms of their use for things like inflammatory conditions like asthma and ENT stuff like sinusitis and whatnot, but basically these can be utilized for chemo-induced nausea, vomiting, so things like dexamethasone, prednisone, you'll see that occasionally. And then our benzodiazepines are actually really interesting. We'll talk about these in neuro. These are like anti-anxiety drugs, anti-seizure drugs. But basically, if you think about like an Ativan or Xanax, like they just kind of chill you out, right? And so they're considered to be anxiolytics, right? They help to treat anxiety. It's a common use for these medications here. And basically, if you ever think about, you imagine like you ever had like really bad sushi or bad food or something like that, to where you got so sick from getting it, even like thinking about the food can make you nauseous again. Same thing happens with chemotherapy, to where if like you got a dose of cisplatin and you're like, oh, that was the worst nausea vomit I ever had in my life, that was horrible, never want to feel that way again, and then you're like, no, you have to come get it next week. They can actually have anticipatory nausea vomiting, where they just anticipating even getting the drug makes them nauseous and throw up. That's an anxiety problem, and so that's why we can utilize benzos for that. They may get a dose of like Ativan beforehand or Xanax or something like that. So we'll talk about those drugs more so in the neuro section coming up later, but just be aware that's one way we can use them. So how do you choose an antiemetic? Basically, it's going to be off of choosing the route is going to be specific to your patient. So if they're actively vomiting, probably a tablet's not going to be great there. So having things like rectal promethazine may be a good option. Having IV agents like ondansetron is something to consider there. And then most frequently for things like chemotherapy, you're going to require multiple drugs. So you may need ondansetron plus aprepitant plus lorazepam plus dexamethasone. I've seen some patients get 4 or 5 medications just to treat the nausea vomiting from one chemo drug that we have to give them, right? We'll talk about that later, though. We get to the oncology section. Typically for motion sickness, so your antimuscarinics are your best bets, like scopolamine, the H1 blockers. Those are going to be the main things you'll see there. And then for most patients, run-of-the-mill nausea vomiting, the serotonin antagonists like ondansetron is like your bread and butter. That's always going to be your go-to 9 times out of 10, most likely. Now, sometimes nausea vomiting is related to stuff kind of sticking around the stomach for too long. So if we want some ways to try to move things along, we call those prokinetic drugs, or causing peristalsis to occur here. We have 2 main drugs in that category. First of which is going to be metoclopramide. While metoclopramide itself does have dopamine blocking capabilities and will decrease nausea vomiting as a result of that, it also has this ability to increase acetylcholine release. You'll find we get to neuro, you'll see there's a seesaw sort of pattern between dopamine and acetylcholine. As dopamine goes down, as this drug will do, acetylcholine is going to go up. We know acetylcholine's actions on the GI tract is stimulatory. It's a parasympathetic nervous system at play there. And so by giving Reglan, we can cause increased peristalsis, increased gastric emptying, and that can also help out with the actual nausea vomiting as well. So we do this a lot for gastroparesis and GERD sometimes. Just be aware of the sedating effects of the metoclopramide. Just know we can use Parkinson-like side effects, which we'll talk more about in the neuro section later on. The other big one we'll see used more frequently is erythromycin. I see this in kids all the time. They have like kind of physiologic issues in terms of decreased gastric emptying. This is a good drug for them. And in fact, I probably see more erythromycin being used for prokinetic purposes than I ever do for infectious purpose to actually treat an infection. But this one in particular will interact with these motilin receptors on the GI tract, and that can stimulate peristalsis. So I'll see this a lot in kids. I see this used in diabetic gastroparesis. So a lot of things there. Good utility with that. Of course, cramps, can be an issue there. And sometimes you can find impaired motility. If they're on this for a long period of time, they can kind of develop a physical dependence to it, where it's hard to kind of take them off of it, because you can get a lot of rebound constipation. So this may be something to try to titrate them off over a long period of time, potentially. Okay, so we talked about nausea, vomiting there. Now to switch to gears, and let's talk about our laxatives. So if we have a patient who's complaining of constipation, how do we treat that? So there's a lot of common causes for constipation, including things like IBS. You can have hypercalcemia, and of course, medications are a huge one here. So like opioids, anticholinergics, etc. So a lot of medications can do this. So it's important to consider when your patient comes in complaining of constipation to figure out like, okay, well, do I want to add more medications onto this patient, or is this a thing where perhaps I can do something with the medications already on in order to treat this, right? So you may find a patient who you can't take off of their opioid because they have chronic pain, but maybe by reducing the dose, or maybe by introducing some other lifestyle change, you can try to treat this rather than just adding on more drugs, right? Because in general, and while more people taking more drugs is job security for me, this is not good patient care. So if we can try to eliminate medications instead of adding more on, that's always going to be a benefit. Obviously, for these patients here, we want to relieve their symptoms of constipation, try to reestablish normal bowel habits, and overall increase quality of life. You will not believe how big of a hit on your quality of life being constipated can have. This is something my wife recognized during her residency in pain management. For her second year residency, it's just that you can have these patients who are on all these different pain medications and they're still just not feeling well. And it's like, oh, they're having all this like abdominal pain and you can't figure out what's going on. Then all of a sudden they have a good bowel movement, maybe due to some pharmacologic intervention. And it's like their pain scales come down. You can take them off some of the opioids. So you really can't, underestimate the value of a good bowel movement in terms of affecting your quality of life. So it may sound silly, but it's true. So our laxatives, we have a couple ways we can help to reestablish normal defecation. So one of the ways we can do is increase motility of the GI tract. We can try to increase the water content of the stool. You'll find that a lot of patients who have constipation, especially chronically, are probably dehydrated chronically as well, or they have kind of low fiber intake and things like that. And then the other big way we can try to move things along are to decrease colonic water reabsorption. And that way you're going to have a higher osmolar load in the actual GI tract itself. It's going to draw more water in. It's going to cause peristalsis to occur just naturally, just due to the stretch receptors being affected there as well. What are we going to do this for, or what are indications here? You may do this as preparation for bowel surgery. So if someone's having a colonoscopy, you want to make sure they're nice and cleaned out, so that way you can get your scope in there and do your thing. If you need to have someone who is maybe having post-operative ileus, for instance, you can help stimulate and move things along in that way. And then, of course, minimizing or trying to relieve temporary constipation is obviously the probably the most common thing you're going to see there. Keep in mind, a lot of these are available over the counter, and so you want to be cautious. Again, I apologize for the screaming child in the background, but it is what it is. A lot of these you're going to find are available over the counter, and so you want to be careful that patients are not covering up the symptoms of something more serious. So if they have underlying issues like Crohn's or ulcerative colitis, you don't want them to be treating the symptoms of that. They need to be diagnosed. So that's why, again, you want to be letting patients know, hey, these are the warning signs, things you want to look for. If the constipation is not improving on its own or getting worse, then yeah, you need to come and get seen. So in terms of like side effects, acutely, you'd expect to see things like abdominal cramping, diarrhea. That's totally normal there. Also, interestingly enough, with chronic use of these, you can get what they call a cathartic colon syndrome, which is also the name of my my rock band in high school. We never made it big, unfortunately, which is why I'm here today. But regardless, you can actually find the overuse of these drugs, especially like our stimulant laxatives, is you can actually end up developing issues of having like mucosal inflammation. They end up having issues with like nerve damage that happens over time. This is not common, but this would be someone who's like taking these high dose laxatives for like, years potentially. So not common, but something just to consider. So we'll look at the different groups of laxatives here. We'll see that they are kind of fitting into three categories based off of their onset of action. So you're going to have things that take some time to work, things that are going to be working a little bit quicker, and then you got the ones that cause a watery evacuation. If this was not descriptive enough, there you go. These are going to be the fastest acting medications here. So we'll look for the ones that work over the course of several days. Those are better for more like kind of maintenance of normal stooling. So you'll have our bulk forming agents, emollients, and our osmotic agents. See drugs that work a little bit faster than that called the stimulants. And then finally, the ones that can cause a acute watery evacuation is going to be our osmotic laxatives again. We're getting into some of our enemas and then our bowel cleanouts. We'll talk about those specifically here. So first off, the bulk forming laxatives, these are most likely just going to be non-digestible dietary fiber. So you can get a decent amount of fiber in through your diet, but unfortunately, if your diet consists of, like a lot of low fiber food, like a lot of like fast food and stuff like that, they may not be getting enough dietary fiber. And this is probably going to be an issue for a lot of your patients that you're going to run into. We see a lot, especially in the pediatric ER, we see a ton of kids coming in constipated. They're FOS, they're full of stool, right? And a lot of it has to do with either they're not getting hydrated well enough, they don't drink enough water, and then also they're probably consisting on a diet of, chicken tenders and mac and cheese, and so they're not really getting a lot of the fiber that they need. So we can replace that. We can basically supplement that with things like psyllium husk, which you'll find things like Metamucil, methylcellulose. A lot of times these come in powders. And they're usually not super well tolerated by patients, mainly because they are very gritty or they just don't go into solution very well, so the texture is not great. So patients may not like it because of that. But ultimately, what they're doing is that they're increasing the bulk of the stuff in the GI tract. They're helping to increase the water content of the stool that increases the motility. It's basically going to be stimulating peristalsis by activating stretch receptors there in the GI tract. The big things to worry about with these are going to be, flatulence and cramps. That makes sense because, again, they're moving things along in the GI tract. But the other big thing is they actually will bind a lot of medications. So I would not use these at the same time as their run-of-the-mill, medications for blood pressure, diabetes, or whatever. This is another case here where I'd want to take interacting medications either an hour before the bulk forming laxative, or probably 3 to 4 hours afterwards. That way you can make sure they don't meet up there in the GI tract, bind them up, and then prevent your other medications from being absorbed, right? In terms of stool softeners, these are going to be things that are used probably a little bit more occasionally than the bulk forming in terms of like routine use, but you'll still see them used with some regularity. This can include things like mineral oil, especially for infants. You'll see this used quite a bit. Things like glycerin suppositories can be utilized there. And then docusate. This is the most common one I see used for adolescents and adult patients. Basically, they can help emulsify the stool. Basically, it's a fancy term to mean increasing the water content and lubricate it. You will find these patients will have almost describe it like the rabbit pellets. Like they just have these like really like desiccated, like hard balls of stool that will come out, and it's just like, yeah, no wonder they're hard to pass because they look uncomfortable to pass. So by using an emulsifier that try to increase water content, it lubricates, and makes it easier to pass. Patients don't have to strain as hard. It can be bad for like cardiovascular patients and stuff like that. You don't want them to have to Valsalva down too hard, increase cardiac strain. So very handy. I'll see these used as sort of like an add-on sometimes to other laxatives, as we'll see here in a moment. You can use your stimulants or irritants, and so these are going to be drugs that directly irritate the GI tract to increase peristalsis. So, kind of an old-time home remedy includes things like castor oil, but more commonly, you'll see things like senna and bisacodyl. These are going to be the most common ones you run into. So, stimulants are very effective at what they do. They work fairly quickly to increase colonic motility. However, you're going to find that you want to use these for as short a time as possible because these are the ones that are more likely to develop physical dependence to them, to where patients are so used to having that stimulation around that they can't defecate on their own. And so you can develop some issues in terms of rebound constipation when you stop use of these drugs. So that'd be one thing to be watchful for, and make sure that they're aware of. Like, hey, use these for a shorter period of time, but it's available over the counter. They can get access to it regardless. So education is important. Next, we have our osmotic laxatives. These are going to be drugs that basically cause an increase in osmotic load within the colon that can help to draw water into it, right? Because if you have a hyperosmolar solution in the colon, that draws water into it, and that increases stretch, increases peristalsis, and causes defecation to occur here. We have a lot of different ones that are available. So we have things like magnesium hydroxide. We talked about that before as an antacid. We have things like mag sulfate. Probably the most common enema you're going to run into is what we call a Fleet's enema or sodium phosphate enema. Again, just a big load of sodium phosphate causes all this water to draw into it, and that causes big stimulation to defecate. And then kind of becoming sort of more popular is polyethylene glycol. You may see this under a couple of names called Miralax or Go Lightly. And again, how you're using these drugs may change how they're going to be defecating, right? So I'll use polyethylene glycol as an example here. So if you just need kind of like routine maintenance of stooling, like if I just had a kid who is like kind of chronically constipated, I just want to give them something every single day to help them stool their normal 1 to 2 times a day. This is where I can use relatively low dose polyethylene glycol. That's where you get your Miralax from. They do like 1 capful a day, and they're usually good to go. On the other hand, though, if I increase the dose significantly, I can get what we call Go Lightly, which is this big 4-liter jug that you mix with water, and the patient has to drink it. And basically, it provides such a high osmotic load that it's going to cause the patient to defecate quite quickly and extensively. And so that's where you do like your bowel cleanouts and things like that to prepare someone for abdominal surgery. I've used Go Lightly in terms of patients who have ingested like a lithium overdose. And so to try to flush that out from the GI tract very quickly, we'll do that. Sometimes we'll do it for patients who are trying to smuggle drugs in across international borders. So, for instance, if you had swallowed a bunch of packets of cocaine or something like that, make it go lightly to try to flush that out. So again, the dose really matters there in terms of how quickly of an effect you're going to get. But again, they're increasing water content, increasing motility to try to flush things through. The route here can matter as well. So for instance, like some of these will come as enemas, which you can insert rectally to cause a very kind of local effect there in the rectum. A lot of these are going to be orally administered, and that way they kind of work from the top down. So that can make a difference. One thing I do want to note here is if you ever have a patient who's neutropenic, so like someone who's receiving chemotherapy, for instance, you don't want to do any rectally administered drugs. So that includes no enemas, but also extends to do no digital rectal exams, no thermometers done rectally. The reason for that is because a lot of drugs like their patients who are neutropenic, they can't really fight off infection as well, right? They're lacking those white cells. So if they have translocation of bacteria in the rectum into the bloodstream, they may not be able to fight off that infection. And that happens frequently to these patients here. So any small tears or anything like that you introduce by inserting a medication or your finger or a thermometer rectally can lead to translocation of the bacteria, can lead to infection, and them getting really sick. So just a little point to note there. Other thing to as well is you want to avoid using electrolyte-based enemas or laxatives in the particularly young, very young, or the very old. So I'm talking about like less than 2, greater than 65, 70 and up. Basically because they may not be able to handle that increased load, especially like the phosphates. Like this is a particular warning with sodium phosphate, to where the FDA was like, hey, don't use these, especially repeated doses in these really extremes of age, because there's cases of death due to hyperphosphatemia. So like if I have a little kid coming in through like less than 1 especially, we'll usually use a glycerin suppository. They're getting closer to the 2 and up, then we can consider using a small dose sodium phosphate enema. For the really old patients, I just recommend avoiding it, especially if they have like kidney disease or something like that. Just something to note. So basically, you want to try to treat the specific cause. If it's due to a medication, if you can try to change that medication, that would be handy there. And most patients could probably stand to get more fiber and water in their diet. So if they can get it through the actual dietary choices they're making, or through like a fiber supplement, that's always going to be helpful there. And then for patients who are more like kind of routine maintenance of stooling, I would probably try an osmotic laxative like polyethylene glycol or an emollient like docusate. Try about 2 to 4 weeks, see how that goes. And then if they're not getting any additional relief, then you can consider adding on a stimulant, probably for just a couple of days, like 2 days probably, right? Now, we'll talk about opioids later on. There's some opioid receptor antagonists you can try to use for those patients, but don't worry about that right now. We'll get into that later. And then if they need an acute evacuation of the bowel, so if they're presenting to their ER, if they feel so bad, they're showing up the urgent care of the ER in order to get relief, they probably want to feel better by the time they leave there. That may be a case where you want to use something like an enema, or some other sort of stimulant laxative, something like that. You want them to work very quickly, osmotic laxative, to go ahead and disimpact them right there. So this is where something like a sodium phosphate enema, Fleet's enema may be very useful. But, consider what your patient's going to be wanting to use it. Some people may refuse it because they may find it embarrassing or whatever the case may be. But just be aware, avoid this phosphate enemas in the very old and the very young. Now, in terms of antidiarrheal drugs, we just have a couple here. These are basically going to be working on the opioid receptors specifically. So we mentioned opioid-induced constipation. That's because activating the opioid receptor with morphine or fentanyl or something like that, it slows down peristalsis. And you'll never find more constipated patients than those that are chronically taking opioids. I mean, they can be at the point where they're defecating once a week, sometimes once every 2 weeks. It gets really bad from that standpoint. But let's say, what if we did this on purpose? What if you had someone who had diarrhea and we could utilize drugs that activate those receptors on the GI tract, but they don't activate them up in the brain? So that way they can get the benefits of slowing down peristalsis, but they don't get the high associated with opioids typically. We have 2 drugs that do this, one called diphenoxylate and the other called loperamide. In terms of adverse effects, yeah, you probably would expect constipation to occur here. But keep in mind, like, why are they having diarrhea? Is it due to an infectious cause? Because a lot of times you don't want them to hold on to all those bacteria or virus, right? So be cautious here for occasional diarrhea, maybe due to dietary choices or who knows what. These drugs can be okay, but for the most part, if it's more of an infectious cause, I would probably hold off on utilizing these because that's the body's protective mechanism to try to clear that stuff out. So it's probably a good thing in some cases. Pepto can also serve as an antidiarrheal in some cases. It being used, especially for like infectious diarrhea, because this is not going to stop the GI tract like Lomotil will, for instance, or loperamide. But this can help out with like excessive intestinal secretions. It also has a little bit of antibacterial activity itself, so you can sometimes see Pepto being used for infectious diarrheas. And again, be aware of that salicylate toxicity we talked about before in kids. So I think that's all the time I really have for today. I don't want to get into the inflammatory bowel stuff just because I don't have time to finish it. So we will complete this next time, and then we will also have, we'll just move on to the next section, which I think is going to be getting next. Yes, we're going to get into the rheumatology. So that's actually going to be a good segue because a lot of the stuff we'll talk about in terms of inflammatory bowel disease leads right into rheumatology because it's basically, a similar pathophysiology in terms of, having an autoimmune disorder. And so the treatments will actually look kind of similar too, as we're going to see here in a little bit. So, any questions before I let you guys go? I don't see anything on the sticky board. But if not, thank you for joining me. I appreciate it. And then I'll see you guys all next time. Don't forget about that prescription assignment. If you have questions, feel free to email me. We can talk it through. But you'll have 2 weeks to do that. And make sure you're using that second part of the rubric that I attached, the part about inpatient medication orders, okay? Otherwise, you guys have a good one.